Hello, everyone. For those joining, give us a few minutes, then we kick this off. Thank you. Hello, everyone. Uh, Thank you for joining us this Thursday. Thank you for last week. We had a bit of some technical issues, but I see there's a number of people who joined us again today. Uh, my name is Eric Asuma, one of the co-founders of the Kenyan West and West Africa Group. And today I'm with Joshua Kakai. He'll go a little bit into the details. Ideally, to discuss what's happening on the insurance side, ideally around risk and the affordability side of insurance, with a focus on the healthcare side. So let's start off maybe with a bit of introduction from our guest. That's Joshua Kakai. Joshua, a bit of intro about yourself, your role at AR, and then we kick it off.
Thank you very much, Eric. I trust I'm audible.
Yeah.
Great. So Kakai Joshua is my name. I work with Minet Insurance Brokers. I'm happy to be part of this conversation. And Eric, it is good that you founded the Kenyan Wall Street and the conversations that have been happening here for a while. Specifically for Minet, I sit within the healthcare division. So how Minet is structured is we have all different types of divisions and risks that are covered. So we have general risk that takes care of the motor and the like. But for today, as Eric has mentioned, the focus is basically on employee benefits division, where healthcare sits. Healthcare is a bit broad, and even internally, we have intentionally structured it in a way that we have both healthcare itself in terms of the corporate and the solutions we're churning out. We have a specific direct focus on preventative healthcare, so we have a fully functional wellness unit, and then we also have the international medical business, which definitely looks at whatever is relevant in terms of that space. I have been in this industry for the last, I would call it 16 or so years, and so the passion that drives me is generally in terms of how do you ensure you solution whatever we are seeing as chaotic or as problems in the market. So the product that you come up with, how do you solution it in a way that you fix a problem that one member, one family, one corporate is having at a time. So that is what drives me on a daily basis. So then we see how do we ensure that our clients are smiling, our clients are happy, and they are attended to.
Okay, good. Thanks for that intro, Joshua, about yourself. Maybe before we kick off to go deeper into the details, for those who don't know about Minet and what Minet does, maybe also give them a little bit of background around what you guys do there.
Thank you, Eric. So Minet is an insurance broker. We have been in this market for for a while, 78 plus years, so that's quite long. Initially, we were trading as Minet, then we moved to Aeon. I know for those who are football fanatics would remember the sponsorship that we used to do in the Aeon days, and then back to Minet, which is fully owned locally and with a bit of shareholding in terms of PE funds. We are in 10 African markets as Minet. However, we still enjoy correspondence, I would say, across the globe, across over 120 markets, and of course with staff complement of around 50,000 plus. And where that is important is we use whatever we are seeing from the other markets to try and craft solutions that work for our local market. A broker, again, to more or less define it further, could be quote unquote equated to an advocate for a client. So our main role is to be a trusted advisor to the clients for whichever class of risk. So yes, healthcare is one of them, or where employee benefits sit. So we have, we talk of healthcare, we would have actuarial, we would have pension, and we would have life. Then on the other classes of risk, so we would have general insurance, which covers the likes of fire, peril, motor, and all the other segments. We also have a robust retail section that runs with retail and SME, again covering the bits for a specific retail client. So in a holistic manner, that is who Minet is. We also have a docket on the insurance, again still with the general business, which again speaks into that market. But in a layman's perspective, a broker is an advocate for the client's needs. And that is what we seek to win the trust, to be a trusted advisor in terms of which direction we can advise a client, a member, a corporate to take.
Interesting. Thanks, Joshua. So maybe the most important thing that I picked up a number of important things. But for me, what stood out there was around we are in many different markets across Africa. And I think that's a winning strategy. Think of a corporate or an institution that has operations across many different countries, working with one insurance broker from risk advisory, and through that entire journey, I think makes a lot of sense, simplifies their work. And
that is very spot on, Eric, because in the current landscape we are seeing, we have a lot of multinationals and even corporates that, yes, as much as they can be local, they have grown to go across borders. And so trying to get, I would say, a seamless experience across borders and same level of service offering, that usually comes into really a good thing.
Interesting. As we kick off, maybe now into the deeper conversation around, how to access affordable healthcare, especially from a business standpoint, and what role risk advisors can play. From where you sit, what do you think have been the key barriers to accessing affordable healthcare, and how do you think organizations can overcome them with the right, risk strategies?
So when you look at healthcare, and I know healthcare is quite a buzzword currently in the local market or local space, and there are many reasons to that. When you look at, for example, the funding spent in healthcare alone, I think the figures that are available publicly is around 700 or so billion worth of money. Of course, the government is the biggest spender on that regard. So definitely it becomes a buzzword. The other key reason why I know healthcare is top of mind for a majority of us is, one, we had introduction of SHA, which of course a number of people have had the hit in terms of additional contributions they are doing. And while that is still the case, we all once in a while get into chamas and groups where we are required to raise some funds for healthcare bill. And again, those are just some of the things that are driving or demonstrate why healthcare is top of mind. It's still quite a touchy or a key discussion point. I would look at the main barriers in terms of health being accessible and classify them into, I would say, generally 5. But even as we look at what these are, I think we usually try and skew our mind when we're looking at healthcare from one angle. So I would try to expand it in a level so that we see healthcare access and affordability is a factor of a combination of, I would say, 2 or 3 factors. So one would say access at the hospital. So to what extent do we make services at the hospitals accessible and at accommodative prices? So that is one angle to look at it. And then the other bit is from an insurance perspective. So you look at premiums and the insurance penetration rate, which has been at a meager 3% for the longest, and just 2 point something to 3%. So the other bit is the insurance penetration rate, and now that ties into how affordable getting a cover is. So you talk about premiums, product design, and things like that. Those are the two buckets I would put affordability into. In terms of barriers into access, so the main challenges that we know or have affected access to healthcare are, one, what is driving the cost. So when you look at the dynamics in terms of the treatment that are being done for healthcare, largely we look at NCDs, that is the non-communicable diseases, which drive, I think, up to 40% of what that looks like. So the disease burden is one of the key areas, and there are factors contributing to it. So one could be late diagnosis into a disease one is suffering from, lifestyle is a factor, and then now the NCDs that more or less contribute to the highest bit of that being treatment. The other key barrier is on clinical pathways, what we would call in terms of standard treatment guidelines. And again, I know in our market we have the KMPDUs and the like to regulate whatever happens with the facilities. But again, we realize that majority of hospitals we have would have their own independent treatment guidelines. And there are a number of challenges that come to it from it being regulated at a national level, which we see in developed markets. The other key bit is providers. So the service providers and the hospitals where members are accessing services. I know we have enough shred of information in terms of what the hospitals are doing. I wouldn't go into specifics, but I know the other day we saw the CS gazetting and suspending around 40 healthcare facilities because of fraud and related activities. A few years back, we had trending headlines in terms of a facility which was giving targets to, staff, whether confirmed or not, to convert or outpatient care into inpatient and things like that. So hospitals is the other key bit. We also have awareness as a gap in terms of members being aware in terms of what their right is, what facilities are offering, what specialty and professions at which hospitals, which diseases they can just do some home remedies and be able to survive and be well. And then finally, which I would now tag to ourselves as the industry, is the products that we churn out that now would either push for penetration rate to be higher and more or less members being able to visit different facilities. So those are the 5 main areas I would put or cluster in terms of maybe systematic barriers in terms of having healthcare as being a bit accessible.
Okay, good. Thanks for those insights. It's quite interesting, and I mean, I don't think much has changed. That penetration has been around 2 to 3% for a very, very long time. And my initial thinking around this was either it was an issue of affordability. That was my main thinking around why the rate is extremely low, or is it an issue of product? I think you've clarified. There's a number of systematic issues there that we need to address. And I tend to think then, it's specifically now on the government side now, they're coming in with some of these programs like social health, NHS that we had previously. My thought process was that we didn't increase the penetration, but I think we'll get into there as well. But from a business standpoint, think of an employer that has a number of employees, from few small SME to a large corporate, to a corporate say operating in a single country, to a corporate operating in multiple countries. How do you think they should work with risk advisors generally to negotiate, say, better healthcare access for their underserved employee groups? How would you advise them to do
it? So there is a straight or a simple answer to that question, but I can go deeper. And the most direct way to answer that is for any employer, for any individual, because again, I started by mentioning we not only look after corporates, but also individuals. All you need is a trusted risk advisor. That is the space we play. And where I'm saying that is the simplest and the only thing you need as a member or as an employer, it's because there is a mandate that is given to a risk advisor. And trust, yes, is a currency that is very rare, but where we sit and where we come from is we build this trust over the years and to just ensure we advocate for the member. So the simple answer to that is, one, you just need a trusted risk advisor. And what they would come to play in your portfolio is more or less, one, assess the situation and see. We have different underwriters, we have different product ranges in the market. They hold the professionalism to understand the technicalities within what healthcare space is. I know from an industry perspective, you usually looked at as salespeople, where you are keen to close the sale and then keen to decline paying of the claims once they're due. So this risk advisor, the key role is to come, walk with you the journey, spot an underwriter or a risk insurer who would be able to take care of your risk, and then interpret the policy document for you. So the policy document are the granular details of the cover you're purchasing. A number of times you usually hear cases of, yes, I have a 10 million cover, for example, for inpatient, but the in limits within which I can access treatment have been capped to $1 million, $500,000, and the like. So the first thing that I would give as an advisory is, one, you need to spot a trusted risk advisor that you can work with and understand the entire journey. Then the other bit is they will give you expertise in terms of look at how the corporate is structured and then design a product that works for you. I can give an example of what we look at when you are working the journey with the clients. Is we look at how would a risk be priced. So we have outpatient benefits, we have dental benefits, we have inpatient benefits, and we look at the premium price that is given to each of those risk cadres. And then from the premium price that is given, you go historically and look at how has the scheme been performing from a spend perspective. And there are models that you're able to propose on the basis of that analytics to say, yes, you can proceed with this product, insure one, fund another one, and then have a combined model that works exhaustively. The other key bit you also look at is, again, when you're looking at the underserved segments, largely we are thinking of, I think, the microspace, the Juakali sector, and the like. Again, we have products that we're able to walk the journey and define for even these market segments for those employers to take care of that. Again, if you're complementing from what the government is offering, and I know you've said we'll get into that a bit later as we go on. Again, you can look at, do I have members, yes, access from out of pocket on outpatient, and then the bigger catastrophic risks, so the inpatient that we like to do insure, so that is the other angle to look at it, and then now you balance it out. But also from a risk perspective, what you have seen hitting a number of our employees is, from a corporate perspective, yes, the employer would give a solution to their staff. But the people who are forgotten and those who we put WhatsApp group for our siblings, our parents who are at home. So again, we've taken the initiative to do that in terms of, if you have a corporate cover, then how do we negotiate a rider or a pseudo group on the site, which can be tagged whichever name, could be ex-employee, umbrella, and then you get a good rate, or could be parents and siblings, then you can be able to insure your parents, your siblings, so then you are at peace, so productivity is up, and then the other bit in terms of access is also taken care of. So those are the main bits I would speak in terms of what you can look at to ensure that you have inclusivity. So as long as you have, yes, a trusted risk advisor, they give you the expert opinion in terms of what you need to do, structure a product that will be able to work, be it a micro, be it a hybrid model, and we can speak and go deeper into each, then which solution will be able to really speak into the industry you are working for.
Good. Thanks for that. Still on that particular topic, from where you sit, can underwriter be a risk advisor, can still be an insurance broker, and play the entire value chain?
So yes and no. So what we have observed in the market is the number of complaints we get, and this is available when you look at whatever the regulator files, is we have scenarios where if you're going directly to get a cover with an underwriter, you can still get that cover direct with an underwriter, yes. However, you need to really invest in having that acumen on what the risk is all about and how to play around with the product. If you do not have that acumen, or you've not invested in your HR team or your staff team to do that, then there are usually scenarios where there are benefits that you could be taking advantage of, but you end up not taking advantage of. So that would be a shortfall. The other key value chain that a broker brings, or an advisor brings on board is they work with all these underwriters. So as Minet, for example, we work with all the 19 underwriters who provide medical insurance services or medical healthcare provision. And so we're able to, from that scope, see which underwriter is doing better in terms of some offering, which one is not. And where we need to negotiate further and have some inclusion in terms of what we can see in another field being played and not in another field, then that comes into play to help you have a very robust cover. The other key bit also in terms of what value chain this broker brings on board is gone are the days where it's just a transactional closure of sale and wait for a renewal. So now we have, for the longest, been advocating for the efficiency of what you have purchased. And the efficiency, I'm looking at what touch points does the broker have with the respective client. So be it pre-authorization, discharge, so that then you ensure all that is done in time. And the number of value adds that again are added on top of it, just to ensure that your servicing and the experience being gained by the client is top notch. So I wouldn't recommend a direct, more or less, procurement of a cover, only for those reasons, so that then you're able to complement whatever is. Yeah.
Okay, good. Still on that side of things, from your view, do you think it matters when it comes to the age group of assuming I'm a company with, say, 100 Gen Zs, and company B is 50, over 50, or over 45? Is there going to be a difference in the pricing?
So pricing, and I'll try to break it down a bit. So when you're looking at premiums and pricing, from an actual standpoint, it's just a product of how you stratify the risk. And when you're looking at stratification of risk, you look at comorbidities. So comorbidities would be the pre-exposed conditions, so the diabetes, the chronic, and all that. That is why when you're procuring a cover on an individual basis, there's usually a step where you need to do the medicals, so that then they assess whatever risk you are. So that is one angle. Then the other bit that informs the risk is the age. So age is a factor. So the older you get, of course, the more susceptible you are to diseases, which means your risk is high, and so of course pricing goes a bit high. And then but that is when you're looking at it from an individual perspective. Now, when you're looking at it from a group-based kind of a model, so we have what we call pooling of risks. And so when we are procuring cover from a group perspective, then these factors will not come into play. So the only bit is, yes, the group will be onboarded. And I know we have had negotiations with underwriters to have what can be considered as a group, so that then it is not too punitive. So that then we have even as small as 10 people being considered as a group. So as long as it is a group, then the bits to do with age and the other comorbidities do not come into play as risk factors. Then finally, to answer the bit on Gen Zs, it's an interesting time that we live in, Eric. And I know initially in the older years would assume that Gen Zs are healthy, and so you are not exposed to any risks. And when we work with that assumption, then depending on those demographics, then you can say you get an accommodative cover. However, what we now focus on, again, value of a risk advisor, is to give data-driven kind of a modality for you to price. And so we'd look at, yes, demographic as one factor, where we have a pattern in terms of history, in terms of spend, is another factor, and then try to craft a solution that speaks into what benefits you want. And I think in the common marketplace, it's what now we are being demanded for as hyper-personalization of covers. So it is more or less looking at data and then using it to price and get a commodity.
Okay, good. Speaking of the innovative side of things, yeah, what sort of innovative healthcare financing models that risk advisors like yourself can introduce, say, to help employers optimize costs, given that's a big cost, for the HR side and to the staff side. What are the innovative healthcare models that you can advise employers?
Thank you for that. So I'll flag them into different segments so that I just break it down, so that then we're able to more or less appreciate whatever that looks like. So from an innovation perspective, we'll look at it from one. Digital is one angle. I know when you talk about innovation, everyone switches to AI, which are the buzzwords, and digitization. which is fine, and I can speak more into terms of what that is being done in that space. But now when you're looking at financing, there's really a component that you really need that advisory in terms of how the organization is structured, the employee outlay, the budget constraints, and the industry the employee is in. So there are various models that you're able to more or less look into the corporate and advice. So one of the key things we look at is, and which informs what these advisories will look like, is one, we don't just come and present an off-shelf product to a client. So we'd come, sit with you, understand your employees, if possible, even do a survey just to see what are the areas of needs, and then look at or understand the journey with you as the employer from a budget perspective and what you're looking at achieving, and then now craft a solution. So now, when you're looking at, for example, a large corporate, there are models to do with capitation, which can be able to be proposed as a model for having the financing. And capitation is more or less where you pick specific set of service providers and then agree on a fixed rate and then pay them, and then your members can be able to access. Now, you realize if the employer has employees spread out and the cover is also for dependents, then that becomes a challenge, which means you need to have capitation across a broader set of facilities across the country or the regions. So that is one angle to look at it. The other bit is to look at the industry or the workforce that is available, and that would inform the bits to do with what products to make. So we can have micro insurance or micro product as a way of handling the cost. So then we have a segment of employees put on a micro cover, depending on how that is structured. Then the others put on an open cover. So again, that also more or less tries to make the cover bit accommodative. The other key one is on hybrid model. So hybrid model I had mentioned earlier, and the hybrid model is where you look at a set of benefits you choose to place a fund with a licensed medical insurance provider. So like ourselves, we sit as a licensed medical insurance provider. And for a number of our schemes, we're able to do fund management as a service. So by fund management, what I mean is we look at whatever spend or whatever cost has been tagged to premium, for example, for dental benefits. And then if it is cheaper to hold that fund and then administer it on behalf of employees, then you go that route. So you have some benefits being funded and the others are fully insured. So the fully insured ones are the ones which are mostly high spend patients and where the risk is high. So the hybrid model also comes into play in terms of helping make the cost a bit easier. And again, the key value in this is since as Minet already licensed to, we are working with independent service provider licenses. So then you're able to fully run the entire hub of administering claims, negotiating rates, and all that bit from administration. So it is less headache. Then the other value that it brings is you do not need to pay in advance the premiums, as is the rule when you're doing a full insurance model. The other bit which you have seen also, which forms part of again financing, is on a gatekeeping mechanism, and we have models where we have facilities that are onboarded by an employer. So depending on footfall, so footfall basically being the traffic, either to do an in-house clinic, and the in-house clinic would go into two models. So there is one which would be fully funded by the employer, again depending on whatever they're looking at achieving, and there's also a model where we as an advisor come and sit with you, define for you which KPIs you can set, go through the entire vendor evaluation process, set KPIs, and then have a provider on premise who would offer services to your employees, and depending on where it is located, even in some cases to some dependents, at a subsidized rate, because you're giving them, of course, the place where to run the facility for. So those are the main models I'll look at from a financing model perspective. In the developed markets, I know there are bits to do with value-based care, which I know even locally we are trying to see if we can achieve that. Yes, there are snippets that have been done into it, and by value-based care, what I'm just looking at is how do we reward outcomes when now members are at facilities. And there are various matrices that when you look at developed markets, the UKs and the like, have been packed so that you look at what is the stay at the hospital, what is the adherence or monitoring of drug regimen, and those things are able out to inform how do you reward a specific facility. So those are just some of, I think, modalities we're trying to combine and see what works best for whichever corporate or whichever. Yeah.
Okay. But speaking of the reward side of things, do you think? I mean, would you say someone who to say exercises or does physical activity, that gets a better chance of getting better rewards than someone who's not active.
Um,
Ideally, call it wellness with
yes.
person. Yeah.
So to give an emphatic yes, I know COVID showed us different things in terms of we had people who are very physically fit and still were able to be affected adversely with the virus. But from a factual perspective, is wellness is the key driver or the key change of the game in terms of cost for healthcare. And I began by mentioning that even as Minet, what we have intentionally decided to do is to have a fully independent wellness unit. And we are talking about wellness, it breaks it down into different segments. So we have physical, which are targeted as lifestyle, and it plays a big role in terms of ensuring how fit a person is, and also reducing some of the NCDs that primarily we treat. So the things to do with flu, GI, so the basic NCDs that usually hit. So physical activity is very important. The other key bit we are talking about wellness is on EAP, that is employee assistance programs, and that tags into stress, mental related diseases, which have really become a big thing. I think the statistics on suicides and how they're increasing are really by the rest of the day. And so the other bit in terms of mental health is also very vital when you're looking at wellness from a perspective. The other key bit I'll look at is on chronic disease management. So I mentioned comorbidities, and when you're looking at chronic disease management, then what we do is we have deployed resources to have very informative analytical tools. And so what these tools are able to tell us is when you load in the data for a spend for a specific corporate or for a specific parastatal, you're able to see what are the visit rates like, for example, in a facility or for a member. And what that usually helps you to do is you're able to flag where there are very many revisit rates at a facility, so that you're able to speculate on that facility. One, to see if they are legitimate, and then two, and most importantly, to the specific member. There are scenarios where you've been able to see that yes, a member is doing very many visits, but it's because they are going to a hospital and seeing a GP, that is a general practitioner. So then we hook them up with a specialist. So again, from a wellness perspective, that really comes into play. So then we're able to hook up anyone with already a predisposed condition to the best specialist in the market on that condition, and then you're able to work within the journey of drug regimen and ensuring that they follow through. So wellness, I'll consider it very key. It is going to be a long journey for us to achieve what we want to achieve. And even part of what we're introducing in the market as Minet is how do you reward then these behaviors that you're considering healthy behavior. And so there are various digital tools that we're trying to deploy that will be able to monitor how active am I from an exercise perspective, what AI can do for me from a nutrition perspective, what expertise do I get from other market leaders, from those who are in the nutrition space to advise me from a nutrition perspective. And then if I comply to all these, how many points do I earn at the end of the day, and where do I redeem them? So it is more or less trying to gamify healthy lifestyle, and which ultimately now will influence the spend influences the premiums, and it is achieved.
Good. Joshua, you have a lot of information that's that could be very, very beneficial to a lot of people, not just the man on the streets, but both even up to the highest level of the corporate side. I wonder if people have this information. But on we tend to take things like financial literacy students, but people don't take health literacy. Students mostly take financial literacy, in my view. From where you sit, how can risk advisor support awareness building initiatives to just make sure that people are aware of this information that you're sharing?
Thank you. So actually, even financial literacy, what you've mentioned, is part of what we scope as part of wellness. Because you realize if you are not doing well financially, your stress levels are high, GI, so it's all a chain, but it's part of it. Now, from an awareness perspective, what we have done, again, as an advisor and working with the different corporates, is we picked this gap quite a bit early. And so what we have intentionally invested in as part of, again, what our wellness team drives is we're able to create focus clubs. And so what focus clubs do is we can be able to create from an industry perspective a focus club that speaks into, for example, nutrition. And we'd have nutrition experts to come in, give talks and all that. We have focus clubs that are targeting mothers, we call it blooming moms. And so they paint the picture of how the journey has been for those who have already been in that journey, for the new moms able to enrich themselves. We don't talk so ourselves as men. We have a men's club. Again, getting the industry in terms of what are the issues to do with men and how do they have a breath and how do they speak into it. So these focus clubs play a key role in terms of what awareness can be created. The other key bit we also do is we do webinars, and we do it on a monthly basis. And so these webinars will be topical. So one, we can usually have corporate specific, so then we speak directly to the industry you're in. But equally, we now complement it to what is happening in the market at the time. And also we look at now the WHO calendar in terms of what is considered relevant. So these three cohorts of both how utilization looks like, what is relevant in the industry, again informs how we are doing that. And then finally, we have taken the lead in terms of, we have picked the gap in terms of, yes, there is information in the market from what healthcare is all about, what risk insurance is all about, what a risk advisor does. And so if you go to YouTube and just type Bima, you'll again get series that we are doing as Minet, open to the public to just educate and tell them this is what a risk advisor does in this class of risk. In this other one, this is what you need to look out for. And this other one, these are the things that you're able to look at. So all this is a combination of different things that you're trying to play from a front-end perspective, just to ensure that then alignment is really there. And again, when you talk about awareness, misinformation usually hits us quite hard. And Eric, I'll give you an example of, we have had a debate, I think, in our market about branded and generic drugs. If you had to take a guess, for example, when you look at the developed markets, what would be your guess in terms of the percentage adoption of branded vis-a-vis generic? So let's say generic, what would be the percentage adoption of it for in developed markets? 80, 50? What would be your guess?
Generic.
So generic, to give it simple, generic is what in the market is perceived as inferior. And then branded is considered originals. And yeah. So
my view, and this is my view, which maybe you incorrect me. The generic ones will be, it's a bit low out there, but the branded ones.
Just give me a percentage, 50, 60, 30?
Probably less than 20%.
20%. Now let me give you a shocker. When you look at, let's take an amoxil as an example. So you're looking at cost for healthcare. You get a branded amoxil, or what is termed as an original. It would cost you maybe $650 or thereabout. You get a similar but a generic one, you get it at $120. So forget about the issues to do with counterfeits and things like that. So now, when you look at developed markets, now to the contrary, the adoption rate for generics is at 80, 90%. And I can dare say that maybe we developing markets and the ones in this other side of the coin are the ones driving the traffic for the branded. Now, when you come to our market, that percentage goes a bit low. It's around 30, 26 or thereabouts. So you can already see the differences. So if truly they were inferior, then of course the adoption rate in the other markets wouldn't be that high. So it's just, again, one of the misalignments in terms of how do you look at cost of healthcare and what constitutes into what feeds into it. I just wanted to give that as an example.
Yeah. Interesting. That's quite insightful. The shocker to me, to be honest. A big shock. I didn't expect that. I mean, my expectation would be that the opposite.
Exactly. Yeah.
Interesting. On to the last bit of this webinar. I mean, as the audience are aware, and I mean, most people are aware, especially from this part of the region, Kenya is transitioning towards the social health insurance fund, and a lot of corporate businesses and individuals are still don't have a clear idea around what's happening. I'll give you a simple example from yesterday. I was having a call with my grandfather, and he had come for checkup, and he was telling, even as simple as he didn't know how to do registration, right? Uh, that's at that level. But now think of a business or a corporate uh, that, or an employer, for example, that's the right one. You know, they need a lot of this advice. From where you sit, what are you advising? What strategic guidance or advice would you know, can employers expect from risk advisors like yourself?
So I have quite a mouthful on that, and I'll go a bit slow so that then we are very clear. So for clarification, I work for Minet, not the government, so that we are very clear. But I'll tell you what, Eric. There's a lot of misinformation in terms of what works and what does not work. The data I've seen, again, available publicly is, I think as at October, we have 22 million Kenyans that have successfully registered for SHA. And when SHA was going live in October last year, I know we had quite a number of teething problems. And what we did as an advisor, again, was to come and walk the journey with the clientele that we had. So we organized webinars, we walked the journey with the SHA officials, we invited them into sessions, and more or less educated our corporates in terms of what does it mean, how do they register, and all that. And we have consistently been drumming up support in terms of even forget the corporate, forget the employer. Even on an individual basis, I need to ensure my parents are enrolled and all those kind of things. And I'll tell you, again, an actual statistic. I have mentioned that we have quite invested in terms of digitization and analytical tools in terms of how we crunch data and see what output to get. So again, we picked a number of policies and we're able to see that same period last year under NHIF, same period this year. In some instances, you'd get that what would have realized that savings or what the government has taken care of under the older regime would have been 1 million. You pick same period current year, you realize that has gone 2-3 time falls for some of the facilities and for some of the services. So realize, again, a reduction by maybe 3.8. So you see that is a single scheme, for example, as an example, and you see that is 3 times. Now, if you go lower now to an individual level, so we have what is working and we have what is still in development. On paper perspective, it is very good. But what we are doing from an industry perspective is we are looking at what is working. And what is working is we look at facilities. So when you look at Kenya, again, big figures. The number of facilities that are registered, I think, are around 14,000 or thereabout. What SHA has, again, publicly mentioned to be on its panel, it's around 9,000. Now, when you look at the split for these 14,000 facilities, you'd get around 2% or thereabout, at 7% at around 2,000. Those are faith-based facilities. The other one is a split between public and private. And now these are the same facilities that even when you take a private cover, you're going to access services from. So it simply shows you there are a number of overlaps in terms of these facilities that are serving the same members. And so what you're doing proactively is to try and see which facilities have the maximum offering from a package perspective. And there are packages that really SHA has done well. So we talk about delivery packages. Yes, it is a meager 34 for CS and 34, but again, it is money that was not there initially. I think it was at 11,000, something like that. Again, it has been defined to have very robust chronic care elements. So surgical packages, again, they are very accommodative within the SHA. And so what you're looking, even the bed rates have gone up. So what you're looking at so that we complement whatever cover a member has is to try and optimize on all these offerings. So one, try and route traffic to the facility, which of course is offering services for SHA. And then while you are accessing that facility, then also try and push as much as possible to ensure that SHA becomes the base in terms of taking advantage of that. And that goes the entire hog of working the journey with the member, getting approvals, and facilitating the back-end process. So then the member just walk into the hospitals, get access, and then the other bits we try and follow up and close on it. So what I would, in a nutshell, put is, yes, SHA is working. Yes, there are improvements here and there that still need to be factored in. But again, there are steps that you're able to more or less start immediately and see how to make our employers more or less realize the savings.
Good. Thanks, Joshua, for that. As we end this, I want you to give your parting shots, to anyone listening, to anyone tuning into this particular conversation around, why it's very important, to have a risk advisor when it comes to choosing your healthcare provider.
Thank you, Eric. I think we have quite covered an exhaustive bit in terms of what are the misses from what an employer seeks to have as benefits for their employees, to what role a risk advisor plays. I think a parting shot would be an employer would need a peace of mind. They wouldn't need to figure out on if they're getting the best deal, to figure out on if the cover they're paying for is working, to figure out on if the employee is able to access cover in times of emergency. So all that is the work of a risk advisor. And that just epitomes what would be considered as quite mandatory for a risk advisor. So I would advocate for any employer out there, and not only an employer, but even from a member perspective. You don't need to think broadly or think big. Having a risk advisor does not come at an additional cost to you. All you need is just reach out to Minet as a trusted risk advisor, and we have the rest of the bit handled for you. So from a negotiation perspective, so that you get the best cover, both from a quote perspective, that is pricing, from a product perspective in terms of the benefit offering, the sublimits, from walking the servicing journey with you in terms of ensuring seamlessness of service, be it pre-approvals, be it negotiation for ex gratia. So all that shebang of whatever comes into value for service offering. And to add a caveat to it, again, over and above what traditionally we considered as healthcare access, now we are having a mutation in terms of what we do as risk advisors. And as Minet, again, we're in the forefront of pushing the preventative agenda. And so over and above, yes, placing a cover and ensuring that runs, there is a key component that we really measure and try to walk the journey with the client so that they're able to ensure holistic value. So we look at what we call as total cost of care, TCOC. And you're looking at that, you're looking at both access and what you're paying for drugs. But over and above that, you're also looking at absenteeism, manner spent in sick offs, and what that impacts on productivity. So all these are just, but again, why you really need to have a solid risk advisor who will be able to walk the journey with you. I think I would stop at that, Eric, and thank you for the session.
Good. Thank you so much, Joshua, for those insightful, for the insights. I've also learned a lot personally, and I hope our audience has also learned something. So thank you so much, everyone who tuned in. I'm looking forward to the next webinar to continue this conversation, and have a good day.
Thank you. Have a good evening.